Evening, everybody, and welcome to this Sunday's live stream, for which I'm going to be covering blood thinners. But before I start, I'll do all the introductions and updates on everything that's happening on my channel. So welcome to those that are already in the chat. Welcome to Cal and Amanda. Great to see you here. I'm sure others will join on once hopefully YouTube gives everybody the notifications, but it's not always that good. Although it does look like it's done it. Welcome everybody to this live stream. If you've got any questions at all on blood thinners, anti-platelets, anticoagulants, please leave them in the comments and I'll work through them one by one. But I have got a few notes of things that I want to make sure that I cover. Hello to Mr. Ranger Lab, great to see you. Oh, raining on the US East Coast. Well, that's a shame because here in the UK, it's been absolutely gorgeous sunshine and I've actually managed to get 2 loads of washing done this afternoon, as well as go to the gym earlier. So I'm on a roll today. And Nightbot has joined us as well. Hopefully Nightbot will behave and not try and quieten anybody today. As it says, if you can like the stream and subscribe, it really does help my channel. After talking to another creator, a nurse over in the US, Ray, whose channel is Life in Vibe, talking on her channel, I suddenly have got over the 500 subscribers. Unfortunately, I am still a long way off actually managing to monetize my channel, because I need 3,000 hours of watch time to hit the first one, and I'm only at 800. So I really do need a lot more videos on my channel so that all my subscribers have a lot more to look through. I did upload another video this week on proton pump inhibitors. I hope you've all had a chance to look at that. All my videos are up permanently, so there's no rush. Just work through the videos as you either have got interest or time. You can always play them on double speed if you need me to speak faster, although most people tell me I talk too fast as it is. And also I will be putting on my community post a poll of what you want me to do my next video on. Hi Tanya, great to see you. I was going to do my next video on can you overdose on vitamin C and zinc, because obviously they're quite often promoted for use for when you've got viruses. People take them in large doses, but you can actually get kidney stones from too much vitamin C. So I was going to do a video covering that. I've also got on my list of things to do is mushroom supplements. Quite a lot of companies that sell different mushroom coffees, mushroom shakes, and there is evidence for some mushrooms, but you actually need to know which of the mushrooms that you're taking. It's like just saying take plants. Mushrooms is a very broad term. But this week I've ended up having a bit of an email conversation with one of our local consultant anaesthetists who works in pain management, and we've been talking about magnesium supplements, and there is some new evidence out there about magnesium supplements for people with chronic pain. So I was actually thinking of doing a deep dive on that and looking at magnesium and pulling my magnesium video up to number 1. So I'll put in that question on my community channel so that you can all vote on whether you want me to do that or carry on with the list of videos I already had planned. So, hi Cal. So I'll have to binge them during my mindless code updates tomorrow. Yeah, feel free. Although I am sorry if I end up distracting you from doing your code. So please don't blame me if you end up making mistakes in your code when you're listening to me. Yeah. So magnesium supplements, they are touted out there. There's many companies out there that tout them as a cure-all for curing near enough everything: muscle pain, joint pain, insomnia and everything. They're no miracle, but it does look like there is a subset of the population that is magnesium deficient. There is things that can cause magnesium deficiency, and it may be part of the answer for some people that have got chronic pain and problems. So Oh, thanks, Cal. You won't blame me. So, yeah, that's excellent. So, while everybody's coming on, I've currently got 6 people on, which is great. I'm going to run my disclaimers and intro, and then we can get started on blood thinners. So, my disclaimer, the information that I'm going to provide in this live stream is only for educational and entertainment purposes only. So please contact your own healthcare provider if you're on these medications and you actually have any concerns. Talk it through with your own healthcare provider before you do any stopping or starting of medication. Obviously, I am going to talk about the names that we use for products available in the UK. Be aware that if you are in another part of the world, they may not be exactly the same. Let me get back. Hopefully, I'm going to change screen. So I've just put on the screen the different medications that I'm going to cover today. Obviously, the list isn't exhaustive, and if you've got any other questions or medications that you want to mention, just mention that in the chat. So these come in sort of 3 categories. Now we have what we call the antiplatelets, and these are the medication that stop the platelets in your blood from clumping together. And these are known as the low dose aspirin, or what some people know as the baby aspirin. And then the ones that are on prescription, clopidogrel, although some people like to call it clopidogrel, prasugrel. I've just realised I've missed an S out of that. That's prasugrel, that is Prasugrel, and tigliclor. And then there's an older drug that's dipyridamole, and there is a couple of newer agents as well. And then we have what we know as the anticoagulants, and these are ones that affect the clotting factors within the blood. And the original is warfarin, which most people know as rat poison, because it is also the same thing that is used for rat poison, although I think nowadays they use other agents for killing rats. And then we have the new agents that are the called the DOACs, the direct oral coagulations, and these are apixaban, rivaroxaban, edoxaban, and dabigatran. And these have all been on the market for a few years now, and there's a lot more people getting used to having these prescribed. And then when something's needed to be given by injection, usually for somebody that's hospitalised, needing to have that anticoagulant during sort of an operation and such, like there's heparin, which heparin can be given as an infusion, and then there's what's termed the low molecular weight heparins that can be given as daily injections, and they're usually tinzaparin, dalteparin, and enoxaparin. So that's a summary of all the drugs that I'm going to go into, but I'll just go back to going, why do we actually need antiplatelets, anticoagulants, and heparin? So, hi Laurie, you're not that late. I've only just got started. I've just been chatting about my channel at the beginning. So usually these are used when something has happened and you've had a clot within your body. Now, clots can happen for many different reasons. And what we mean by a clot is basically the same as what you would see as a scab on your skin, actually internally, and causing problems internally. So normally the whole point of a scab is if you scratch the surface of your skin and blood is escaping from your body, that is not good for your body. You don't want to be losing blood out of your body. So this is where your platelets are activated. So these are little mini blood cells, colourless to white. So they're not your white blood cells for your immune system. They're little other cells. And when they see the inflammation at a cut, your body sends inflammation markers for the platelets to go to the area of the cut, and they start clotting together. So they start clumping together to provide a blockage to stop blood escaping out of your body. And they clump and they combine together. There's a whole load of clotting factors that are part of this, loads of messenger chemicals, and they all clot together, provide the scab. It then goes hard and it stops the blood escaping from your body. And that is brilliant. And that is what it's supposed to do when your body actually has a cut and it's escaping out. However, sometimes this process is happening on the inside when it shouldn't be happening. And if you've got a condition where you've got a lot of inflammation going on in your body, you've also got high cholesterol, you've got inflammation in different arteries and your capillaries, and these platelets can start building up and other clotting factors can start building up, and you can end up with blockages in some of your capillaries and in your arteries. So if the blockage is in your heart, in the tiny capillaries of your heart is one massive muscle, and if blood can't get flow to a part of that muscle and it can't contract, you will get what's called a heart attack, of varying different things, or myocardial infarction, because the infarction is the fact that blood can't get to all of the muscle and it blocks off. So lots of factors can increase your risk of that. And the same happens if it's in your brain. So any of the small capillaries in your brain, and there's tons of thousands of small capillaries in your brain, because your brain is such a complex organ. It's all convoluted and folded in on itself with the blood vessels going through it all to feed all the neurons in there, the tens of thousands of neurons in your brain. But if you get a clot in one of those capillaries, it can prevent blood flow going to the section of brain and killing off a section of your brain. Depending on where that is in your brain, results in what the stroke results are. So if it's only a small part of the brain, or it only blocks it temporary for a small amount of time, that's what's called a transient ischemic attack. And then if it's a larger amount of area of the brain, or it dies for a longer period of time, that's where it's a full stroke. And depending whether it's the left side or the right side of the brain will then depend on whether it's the left side or the right side of your body that gets affected. Now it's the opposite way. So the left side, the left side of your brain controls the right side of your body, and the right side of your brain controls the right side of your body. So that's how they can tell, and they'll obviously quite often do a CT scan or an MRI scan to find out exactly where the clot was. And depending on whether it's just on the motor centre, whether it affects just the motor skills, or whether it can also affect memory and cognitive function as well as speech. So speech, not just because of the control of the mouth, but also the speech centre, where you're actually controlling sort of the thought processes to create speech and language. Hello, Angela Glass. Great to see you here. So, and then another two major types of clots is what's known as a DVT, which is a deep vein thrombosis, which is a clot in your leg. It usually results in the leg swelling, the leg becoming bright red, swollen, hot, painful. It is a medical emergency, and any leg that looks like that, it can be very difficult to tell a deep vein thrombosis apart from cellulitis, which is the major infection of the skin of the leg. So either way, it's up to the hospital for a scan on your leg to try and see what the cause is. And a deep vein thrombosis clot can travel up to the lungs, and if it blocks a section in the lungs, that's known as a pulmonary embolism. And the treatment for all of these clots, if you can actually get to hospital while the clot is still there, the clot is still in place, and the clot is causing the problem, will be to actually give you an anti-clotting agent. So either heparin or warfarin or one of the other agents, or actually anti-clotting factors. There's a whole range of things that the hospital can give immediately to help bust the clot. So we usually call them clot busters. So they're given immediately at the hospital to bust the clot open, allow blood to get back to the heart, the brain, the legs, the lungs. Hi Ray. So I had this is the nurse that I was talking about earlier on in the live stream. If you wanted to go across to her channel is great. She has a look at some influencers and then actually critiques what the influencers are saying online from a nurse's perspective on what actually they should be doing to help their health and promote a good, healthy lifestyle and how they should be helping themselves with their diabetes and such like. And I have emailed and had some good discussions. So hopefully we can do some things together in the future. So quite often after having a clot, one thing I was going to say, your clot risk can be raised for many different reasons. As you get older, your risk of having clots can increase, as can your risk of having heart attacks and having strokes. The older you get, the higher the risk. Having high blood pressure can increase the risk because there's more pressure in the system that's causing inflammation and stress on those capillaries and pushing the clots around. There's, cholesterol levels. Cholesterol can actually cause inflammation in the capillaries and increase your risk of clots. So many different factors. One of the risk factors of other medications. So oral contraception quite often gets a bad rep for increasing the risk of clots. Now, one thing that isn't usually put into perspective with that is that one of the other biggest increases in the risk of clots is pregnancy. So say you were having your risk of clot in your sort of 20s or 30s as a healthy young woman, your risk of clots is going to be sort of like 1 in 10 or 20,000. It's going to be very, very low. And then going on the contraceptive pill could double that risk. So it could increase it to, 2 in 10 or 20,000. So still really low and not that great. But actually increasing during pregnancy, the increased risk of clots increases 9-fold. And actually that is a much bigger increase in risk than being on contraceptive pill. So still a very low risk for a healthy young woman being pregnant. The risk of the clots is still very low, but it is significantly higher than the baseline. And this is the thing with risk factors. We always have to think about what is the overall risk. Is there anything that can be done to reduce that risk? And what are the alternatives? So yes, being on the contraceptive pill has increased the baseline risk, but that baseline risk is a lot lower than being pregnant. So when you actually put those two in balance, it probably is an acceptable risk. Also, you need to take into the person's increased risk. So somebody that is overweight is at increased risk of clots. Somebody who is sedentary, increased the risk of clots. So yes, Cal, you are correct that lack of movement increases the risk of clot because that blood is not getting pumped around. You're not actually sort of flushing through the system. As you probably, most plumbers know, if there's not the water flushing through the system all the time, you can get things settling and causing problems. Same in your body. The more that you can actually keep that blood flowing and supplying fresh oxygen, fresh nutrients to all parts of the body, the better that is. So yeah, somebody who's sedentary, and that's why people on going on a flight are at higher risk because you've got a lack of movement. But it's not just going on a flight; it can be going on a very long train journey or a very long car ride if you're not actually stopping, getting up, and moving, and allowing your legs to have movement. There is the added thing with the low pressure as you go on a plane causes a slight increased risk. So that's why some of the very long haul flights can have an increased risk. And things that can be done for that is if you do get swelling of the feet when you travel, wearing compression stockings can really help. And if you've got swelling in the legs for whatever reason, that is a risk factor for having clots in the legs. And people with varicose veins may be at risk of clots. So again, compression stockings and movement to move the muscles in the lower leg to keep them moving can really help as well. So, oh, that's okay. You can watch it from your other account. It doesn't make any difference to me. It's just whether which name pops up if you do chat. I quite often use my other channel to go on watch other creators. So there's so many different things that can increase somebody's risk of clot. So if you've had a heart attack or a stroke or a clot, you will have a talk about sort of any lifestyle things that you can do to modify to help reduce your risk of clots in the future. And they will go through a whole host of other things. So they'll look at your cholesterol, see if helping lower your cholesterol can help reduce your risk in the future. Look at your blood pressure, see if reducing your blood pressure can lower that risk. Another one is checking your HbA1c, which is your average sugar level over the last 3 to 6 months, to see if you're either diabetic or pre-diabetes, because that can increase the problem of the fragility of your blood vessels and the risk of clots. So all of these factors will be put into consideration. Usually if you've had a DVT or a PE, or you've had several heart attacks or several strokes, you'll be getting put on an anticoagulant. And then antiplatelets are generally used more for people post heart attack, angina, or of higher risk of cardiovascular issues. Now, the choice of which one is totally dependent on the person, their other risk factors, and which ones have been studied. So all of these have been studied many different times. They've done very different regimes of combinations of them to see which is the correct one to use and which one isn't. So I'm just going to go back to the antiplatelets, try and keep myself in some sort of order. So antiplatelets are usually for prevention of heart attacks, prevention of strokes, and after either the first cardiac event or a smaller stroke or TIA. And then there's the choice of the different agents. So there's the low dose aspirin, which has been the gold standard, and all the other drugs that have come since have always had to be either in comparison against aspirin or the trying of the two together versus aspirin. So they no longer do any controls against placebo, because they did aspirin versus placebo and know that aspirin works, even though it does come with the risk of side effects and problems, but they know that works and that's the gold standard. So all the studies for the future, the drug has to show that they've got non-inferiority. So that means they are as good as aspirin to be able to get licensed, and then they work out the correct dosage and combination. So often the dosage will depend on the type, and quite often they will use a combination of two. So quite often for the first 12 months following a heart attack or an event, you will be on a combination of two. And if at the end of that 12 months you don't have another event, you'll drop down to just needing one. If you do have another event, then you'll need to carry on for another 12 months from the most recent event. And if you keep having multiple events, then they may decide whether they need to step you up onto multiple agents or moving you onto an anticoagulant. So aspirin and all the others, we do know, so they reduce the clotting of the platelets and how the platelets actually attach to each other. And they help stop them being so sticky. So they don't actually thin the blood. Oh, I think I actually forgot to say hello to my mum and dad. So hello. I realised you've sneaked on and I've not actually said hello. So they don't actually thin your blood. The viscosity of your blood stays exactly the same. So the viscosity of blood moving around at all times stays the same. In fact, the viscosity of the blood doesn't really change much unless you happen to be dehydrated. Now, if you are dehydrated and you've taken more water out of your system, then there's more blood cells and salts and such like in your blood, and your blood is a bit thicker. So being dehydrated can be a risk of causing problems within your body. So that's why they always say try and keep hydrated. But if you are of normal hydration, the actual viscosity of your blood doesn't change. But what does happen with the antiplatelets is those platelets that are floating around that should go into action when you have a cut and form a scab, they are not as effective and they don't do that as quickly. So for all people that are on antiplatelets, they have to be aware of this, and they always have to tell any doctors or even any cosmetic people that they're on antiplatelets if they have anything to do with that could potentially cause a cut on their skin. So if they were going to go for a cosmetic procedure, something like Botox, where you're going to be putting needles through the skin, you're going to be causing little bleeds. The person that is giving the Botox needs to be aware of that, and that you are actually going to bleed out a bit more. And you need to be aware that if you get a cut on your body, you're not going to seal that cut with a scab as quickly. So you're going to have to do more first aid than you normally would, more of elevating the area of the skin up. So if you put your hand, keep your hand above your heart so that there's less blood pressure up there and it can start sealing, putting on a bandage, keeping an eye on it, and if it doesn't actually seal and get a scab quick enough, to actually go to A&E and see what's happening. The other thing with all the antiplatelets is that they do irritate the stomach lining and increase the risk of a GI bleed. Now, everybody always thinks that this is as you actually take it, the tablet in the stomach causes that. It isn't. It actually does this systemically via the blood side of your system. So even taking the low-dose aspirin, people used to take the enteric coated, so it had a special coating on it, so it didn't actually dissolve in the stomach. It waited until it was in the intestines. And they would take it with the meals, so that it would slow the digestion and it didn't irritate the stomach. And although these do come with causing immediate indigestion, that isn't the way that they cause stomach problems and bleeding. It actually is systemically. So there still is the increased risk of this. And this is where quite often the antiplatelets will quite often be given with the proton pump inhibitors, especially for somebody that is older, so over 65, over 70, somebody that's already had a history of gastric ulcers or problems. They will also be given PPI cover as well to help prevent that irritation and damage in the stomach. Obviously, I did cover that, so if you wanted to know more about proton pump inhibitors, you can look back at the video I released this week to see whether you should be on it or not. What it doesn't do is proton pump inhibitors, they're only protecting the stomach. They don't protect any other bleeding from any other part of the body. So the antiplatelets will still increase the risk of bleeding from your skin, from any other part of your intestine. So for hemorrhoids that bleed, it will still increase the bleeding from them and such like. So it is specifically the PPIs only provide cover for the stomach. Now, when it comes to the anticoagulants, they don't actually affect the stomach and cause any irritation or damage to the stomach that will cause stomach bleeding. However, if you were to have stomach bleeding or such like, it would be the same as the antiplatelets. You would be at risk of a higher risk of bleed out. So that's all with all of these, the antiplatelets, anticoagulants, heparin. You've always got to do the risk of bleeding versus the benefit. And quite so when a GP is thinking about either an antiplatelet, an anticoagulant, or heparin, they will do two risk scores. One is the risk score to see whether they will provide benefit at preventing a future event, heart attack, stroke, or clot, versus your risk of bleeding. And they use a risk stratification called HAZLED. And if your risk of bleeding out and having serious complications for bleeding out, they may decide that it's not worth having the preventative against the other thing, preventing against sort of the clotting issue. And that is something that should always be discussed every sort of 5 to 10 years. Is the medication I'm on going to provide me benefit over the next 5 to 10 years? And then at some point in everybody's life, and this is something that we have to think of for older people that are in nursing homes and coming towards the end of life, especially when they may not have that same capacity to make these decisions, is how long are we expecting them to live? What quality of life do we want for them? And which is going to be better, reducing their risk of having a bleed or reducing their risk of having another stroke or heart attack? And are we just going to try and help reduce their tablet burden and just enjoy the life? Very difficult decisions to have, but those are the sort of decisions that if you can think about them when you're much younger, when you get older, it can take that stress off people's families because you actually have made decisions. Right, I've suddenly got very dark on that, so I'll come back. And let's go back to the beginning. So quite often, as I said, pregnancy can be quite high risk for clotting. So if somebody's had maybe a DVT or is obese or has family history or other reasons where they're at high risk of clotting, antiplatelets are all contraindicated in pregnancy. Anticoagulants are all contraindicated in pregnancy. So they quite often end up on these low molecular weight heparins, the tinzaparin, dalteparin, and enoxaparin. And these are also used quite often when people are having operations. So we know that the anticoagulants reduce the risk of bleeding, and somebody may be already on them anyway because they've been at high risk of a clot, had a DVT or such like. But if they're going for surgery, when you're having surgery, you've got to cut through several layers of your body, your skin, your muscle, and there's blood vessels feeding all of those. And the last thing that you want is something within your system that's going to cause you to bleed out more. You're going to end up needing to have more blood transfusions during the operation. You're more likely to bleed out and have complications. So quite often they need to stop any anticoagulants and antiplatelets prior to the surgery. But then actually post-surgery, you're then at higher risk of clots again because you're immobile, not able to move, and actually having the surgery can move things around and increase the risk of clots. So you need something then quickly back in the system once you've been stitched up, once you've made sure that everything's been sealed. And that's quite often when tinzaparin, so the low molecular weight heparins have gone. And you've probably come across a lot of people where they've been into hospital and then they've come out of hospital and they have to have those horrid injections into their stomach that causes bruising, either once or twice a day. Now, I am sure that Ray will be able to say the nurses on any surgery wards are very good at doing these calculations. They have a whole sheet of somebody coming in for surgery, working out what their risk factors of having a clot is. You'll get, when they work out what your risk of a clot is, the first stage is if sometimes even some of the lowest rigs, you get given the lovely, sexy TED stockings, the support stockings to help keep the fluid up and out of your legs and into the core of your body where it's needed and help prevent the clots in your legs. And then the next step, if you reach the next threshold, is to have the low molecular weight heparins either for just a few days or maybe even for 10 days, 2 weeks. And the reason why they cause so much bruising is because of the fact that they're helping reduce the clotting. So when you inject it, those blood vessels around don't clot very easily, and the blood seeps into the skin and the muscle, causing such a big bruise. So they always look really scary, and they can actually be really tender as well. Um, so I'm just wondering, does anybody actually have any questions or comments? Am I explaining that okay? I just realised that I've just waffled randomly for half an hour, so I hope I've actually put it in some sort of sense. Uh, According to this, I still do have 7 of you online, so hopefully I've not lost all of you. And then I might just go on to warfarin, because warfarin is one of the most complicated, and then I'll explain why the other ones are now taking over. Excellent. Yeah, they did, yes. The dalteparin does cause some lovely bruising, but it is doing an important job at stopping any clots forming in them high-risk days after surgery. So warfarin, good old rat poison, which did used to scare a lot of people off it. They thought if it's poison, it's not, it's not safe. But as I hope that anybody that's watched my channel before and watched the same sort of people as I, it's always the dose that makes the poison. Anything in a high enough dosage can be a poison. Even water in a high enough dosage can rid your body of salt and actually cause death. So the dose, the dose is what makes the poison. So with warfarin, it stops your body clotting. It affects the clotting factors rather than the platelets, and so you do have more bleeding. So the clots take longer to form, and that's the reason why it was always used as a That's the reason why it was always used as rat poison, because basically it just causes the rats to hemorrhage and bleed out and die. Not pleasant at all, not the kindest way. There's much more humane ways to kill rodents if they're in the wrong places, or just leave them alone somewhere further away. Yeah. Uh, Laurie, Eloise is the brand name for the apixaban, so I will be coming on to that. So yeah, and yes, really increased risk of bruising, so they need to keep an eye on that. And if they're getting significant amounts of bruises, they need to be letting their healthcare provider know and decide whether the dose needs adjusting. But I'll go on to that. Yeah, too much water can be a poison. Yeah, you've watched the same things that I have. Especially when you call it dihydrogen monoxide, and really scare all those people that don't like chemical sounding things. 2 hydrogens and 1 oxygen. And then there's also the crazy MLM out there that's trying to say that you need to add hydrogen to water, because water doesn't have hydrogen. But yeah. Cal said, I wear compression stockings all the time because I do have a tendency to bloat due to an accident. It's kind of reassuring that it was a good call to me to do, so it limits the risks. Yeah. So yeah, if you have got get swelling in the legs, compression stockings are a really good thing to help with that flow. Obviously, the other thing that you can do is in an evening, if they have swollen up during the day with whatever activities you do, if you actually sit with your feet above your kidneys. Now, this is the one thing that people are quite often set with. If they've got fluid on their legs and they're told to sit with their legs up, quite often they'll just put them on a little stool. I know my granny used to do that. She used to just put her feet up on a tiny little stool, but there was still a good, sort of 12 inches between where her kidneys were and where her feet were. So gravity was still pulling all that fluid down to her feet. You actually need to put your feet above your kidneys. So really sort of laying on the sofa and actually putting your feet up on the other side chair arm, or getting a really decent stool and putting some pillows on it, which is what we ended up doing with my granny, is giving her some pillows to put with her under her feet so that her feet were actually above her kidneys. And do that in the early evening, so it gives your time for your kidneys to filter that and allow you to go to the toilet a couple of times prior to going to bed. Otherwise, you'll end up needing to go to the toilet in the middle of the night, which isn't as convenient. Oh, Kangen water and the pH. Yeah, yeah. Really, water is water is water. You do not need to change the pH of the water. You could throw some bicarbonate soda in your water and make it a higher pH, but it's going to do nothing for your blood. Your blood is excellent at keeping it within 0.02 of neutral. So yeah, we do not need to try and change the pH of our body. If you are in ketoacidosis, it is a medical emergency. Yeah, we don't want to be trying to alter it with different pH'd foods and waters. Right, so back to warfarin. Yeah, it can be a poison in very high doses. Now, what we do with warfarin is we very closely monitor it. So there is what's called the INR, which is a measure of how fast your blood is clotting. So everybody that's on warfarin will end up having to have blood tests to test their INR. And what they do is they put a drop of the patient's blood into a test tube of a certain type of fluid and basically see how long it takes to clot. The quicker it takes to clot, if it's at normal, it's a 1. If it takes double the time, it's 2. If it takes 3 times the time, it's a 3, and you work your way up. Usually for most people who have had a DVT or a PE or a stroke that's severe enough or enough heart attacks severe enough to actually need anticoagulant therapy, or they've got heart valves fitted, they usually need a range of between 2 and 3. Now, there is some mechanical heart valves where they like to have the value between 3 and 4. And if somebody's had multiple events, they like to keep value between 3 and 4. So they'll have regular blood tests. As they start the warfarin, they start usually on a loading dose, which is usually 996,633 of the milligrams for the first week. They test the dosage on after 2 days, after 4 days, after 6 days, and seeing if it's coming up into normal range. As it comes into range, they lower the dose, and if it goes above the range, they lower the dose quite a bit more. If it goes back below the range, they increase the dose, and they do that. They extend the blood testing, so then they'll do it once a week, once every 2 weeks, once every 3 weeks. And sometimes it can even get extended, so it's just one test once every 3 months if it's really stable. And keep it there either between the range of 2 and 3, which is the usual, or between the 3 and 4. Unfortunately, there is so much that can affect warfarin levels. Warfarin has got the biggest amount of interactions of any drug. It is alarm bells with warfarin and any other drug. It's like, just don't remember what the interactions are with warfarin. Just assume warfarin has an interaction, check it. And even if it's not a known interaction, there's always that odd patient that will have an interaction with another medication, and they'll be the first to be that case study to say, now warfarin interacts with this medication. It likes to interact with other things that affect the heart, other antiarrhythmics. It likes to affect with antibiotics, like antibiotics do like to interact with things. Interacts with so many things. So anytime you start a new medication while on warfarin, it's always useful to have an extra INR test anyway after 1 or 2 weeks. And I was just about to move on to that, Cal. Yes, it does interact with fruit foods. Now, not as much grapefruit. Now, grapefruit interacts because grapefruit juice, and it's an enzyme in grapefruit juice, not in grapefruit. So actually eating grapefruit itself can't really provide you with enough of the enzymes. It's when you're having grapefruit juice extracted, and it's an enzyme in there that can provide a lot of interactions. It acts on an enzyme in the liver that helps metabolize many things, things ending in azole and ketoconazole and stuff like that. It interacts with so many things, some other heart medication as well. Warfarin doesn't really work on that pathway, although grapefruit can affect it. It's more any foods that contain vitamin K. Now, the way that warfarin works on what we call the clotting factors. Now, vitamin K is essential in making these clotting factors, one of the jobs for vitamin K. So if you actually take more vitamin K, you're actually going to make more of these clotting factors and work against your warfarin. So if you suddenly decided that you were going to really start eating healthily, start having your kale and all your other green leafy vegetables that are very high in vitamin K, you'll actually then be fighting against the warfarin. The warfarin won't be working. You'll lower your INR and then be at risk of a clot. So we really do say to anybody that's on warfarin, no sudden step changes with your diet. And if you do have changes, inform your nurse. You may need extra blood tests. Now, that also fetches onto the fact that if somebody has a high warfarin, what is the antidote? And the antidote is vitamin K. So if we get somebody and their routine INR is very high, the antidote to that is vitamin K. The problem is that it's also a medical emergency because you could take vitamin K tablets, but they can take 16 to 20 hours to take effect. And if you've got somebody that's got such a high INR, any slight knock could cause severe internal bleeding. You then think, oh, well, we could give them an injection. But what is an injection? An injection is a route through to a blood vessel. And by doing that, well, if you did it into the muscle, that would be a definite no, intramuscular, because you would then just cause a rupture within that muscle and the person would just bleed out into that muscle and it would be a horrendous mess. A major sort of bruise, that whole muscle would just explode with blood. So intramuscular vitamin K is not an option. It actually has to be directly into the vein in the emergency room under supervision. The amount of times that it's literally get an ambulance to get the patient up to the hospital to get the thing, or we have done it the other way of send it in a taxi with a nurse, the nurse do the injection at home with the ambulance on call just in case. But yeah, warfarin is reversible with vitamin K. Now, when these new DOACs came onto the market, the apixaban and rivaroxaban, they were great. They don't need as much monitoring as the warfarin. And so there's not that need for blood tests every few days and then every few weeks. It is also a standard dose. So there's not this up and down in the dose, having it in 1 milligram, 3 milligram, 5 milligram tablets, having the risk that the patient's going to take the wrong type of tablets while they're creating the dose that they need. It is just one set tablet that they take. However, when they first came on the market, there was no reversal for them. And if somebody was to have a bleed or they was to end up in A&E for whatever reason, because they were in an accident, under trauma, or they were suddenly going to need to have an operation, there was no way to reverse it. Now, there is now things on the market. Firstly, it was they would infuse them with blood clotting factors from blood. So they would take somebody's blood that they had given in the blood donation and extract all the clotting factors out of it and use that to give to somebody as an antidote. Now they actually have got antidotes for apixaban and rivaroxaban to give to people to reverse if they're actually having bleeding while on them. But they are mega expensive. They are about £4,000 or £5,000, and obviously each A&E needs to keep hold of a couple of them so that they've got it on hand, because it's not the sort of thing where they can go, oh, shall we order it from the wholesalers while the patient's laid there on the bed bleeding? They need to actually have it in stock all the time. So now it comes to the monitoring of the apixaban, rivaroxaban, and then they do need monitoring because most of them are excreted renally, so they need to have accurate renal function. You also need to have an accurate weight, because the weight of the patient is important for the dosing and for checking what the renal function is, because it's not just to check the creatinine levels. You actually have to do a creatinine clearance calculation that also takes into account the patient's age, sex, and weight to work out exactly what their renal function is. And as their renal function lowers, you need to do that test more frequently to make sure that you are keeping at the correct dose. So if you've got somebody whose renal function is getting to stage 4, you could end up needing to be doing that blood test every month, which isn't actually that much less than if they've been on warfarin. So, and then at that point, you then need to again work out which is the higher risk, the risk of having a clotting episode to the risk of having a bleeding episode, to balance which is the higher risk, which is more important to the patient, which is more important to the family. So, yeah. I think they still do have some interactions, but they don't have as many interactions as warfarin. It's not like a ding, ding, ding. They check everything they're on. It is a more confined list. Right. Again, I've covered a whole load of information that I've just blurted out on you all. So have any of you got any questions? Is there any subjects that you want me to move on to? I sort of covered randomly all the notes I wrote down at the side here. Obviously, I'm here to answer any of your questions. All I would say is, if you do know that anybody that is on any of these, do know that sort of they are at higher risk of bleeding and that they need to be letting anybody know that. And always to remember that the risk of internal bleeding as much as external bleeding. So whereas when we normally fall over, there's not that much risk of an internal bleed. They are at higher risk. So, and if somebody's on that, even if they're in just a minor car accident where you would think it's fine, they still need to go to hospital for a full check over. Okay, so Mr. Ranger's like, yeah, there is so much about these agents, and it's something that I think everybody needs to be aware of, because they're using them for more and more people. So, and Cal, yeah, you're enjoying the info dump. I'm very good at doing info dumps. So if you've got any ideas for future live streams that you want me to talk about, or actual videos that you want me to create, I do find live streams much easier because I don't panic about the ums and the ahs, because you still listen to me on a live stream when I'm umming and ahhing. Whereas when I'm making an actual video, I like to cut all the ums and ahs out and keep it. It's not alternative. Yeah, I know. I can understand why the consultant told you off, but you are technically correct. It's an alternative to rat poison. Yeah. They don't quite like us calling it that. So, but it's quite often what I do talk to when I'm talking to patients, how I explain it in the first instance, because it's something that triggers a memory for them of things. Minimizing bleeding risk. Now, yeah, it's a matter of just being careful. Obviously, somebody that's got an increased risk of bleeding, they need to be very honest with their healthcare provider. Now, one of the things is quite often that high risk is hemorrhoids. And a lot of people are quite often scared to say about the hemorrhoids, but there can be an indication of other problems as well. And you can actually lose a significant amount of blood from hemorrhoids. And I do know most care homes are trained on, if they see blood in the stools, to get it investigated. And that is really important. Also, because if the blood's from further up, it could show that there's internal bleeding higher up in the intestines as well, which again is a medical emergency. It is a matter of being careful, but what we don't want people to do is become too sedentary, because being sedentary also raises the risk of the clots that they're being treated for. So people need to do safe exercise that's suitable for them. We don't want them to avoid doing things. Um, and yeah, as you said, making sure that, yeah, shaving. And as I said, walking around, a lot of people, again, with people with diabetes, because of the peripheral nephropathy, they might not actually feel things on their feet. So I forget to say so. Ray said so things for lifestyle, shaving, not wearing shoes in the house. So yeah, so shaving is obviously a risk factor for cutting yourself and then bleeding. So having a safety razor that's not going to electric. So for a man, an actual safety electric shaver that's not going to cut as finely. So yeah, they probably won't be able to have a baby bottom smooth thing, but just sort of a lighter shave. And again, for women, they might still want to try and keep their underarms and that, but more go down to an electric safety shaver, and then wearing shoes in the house, keeping those feet protected, because walking around and getting a cut on your foot, and as I said, diabetic neuropathy, you're not always aware of feelings in your feet, so you might walk around and then realise sort of 5-10 minutes later that you've been bleeding around all over the flat thing. And I had that. I'm not going to mention, but I did have a friend that mentioned that she's needed a new carpet in the bedroom because she was wandering around and didn't realise that she'd cut her toe and she'd bled all over the floor. Now, obviously, if you've got on one of these anticoagulants or antiplatelets, and you lose a significant amount of blood doing that. Yeah, so again, if you are going to wear gloves, you need to be aware that it's wearing gloves to protect yourself, but also keeping an eye that you're not just keeping your fingers hidden and you don't know what's actually going on with inside the hook. You need to be able to keep an eye on your skin and not just keep it sort of hidden out of sight. Right. Menstruation. Okay. The blood that you're using from menstruation isn't actually directly from blood vessels. So the using an anticoagulant or an antiplatelet isn't necessarily going to increase the blood flow because it's not actually blood flowing. It's the lining of the uterus that has been created that is no longer needed, that is leaving. So although it contains iron and is of a similar consistency to blood, it isn't actually blood. Now, when it actually comes to aspirin, aspirin is a acts on the prostaglandins, and I think some of the other ones do as well, but I wouldn't without actually checking up. Aspirin will actually reduce the blood flow from menstruation, and as does all the other NSAIDs. So naproxen and ibuprofen are actually two. So although being on any of the other NSAIDs, so all NSAIDs have an action on antiplatelets and can slightly increase the risk of bleeding. Which is why NSAIDs are always something that you've always asked for when you fill out forms for tattoos and things like that, because you can increase the risk of bleeding, and then you're supposed to stay off NSAIDs before you have operations because they can increase the risk of bleeding. But NSAIDs actually reduce the amount of menstruation flow, and the best one out of them head to head between all the NSAIDs. The best one is naproxen. Naproxen is the one that will reduce the flow of menstruation by up to 50% because it's actually acting on the prostaglandins that are actually causing the contractions and the menstruation. So it actually has the opposite effect of what you would think of, but actually the antiplatelets, aspirin, and all the other NSAIDs actually reduce the flow through menstruation and the pain as well. And one thing I like to say is a lot of doctors have historically used mefenamic acid, which is an NSAID for menstruation, but actually the high dose of naproxen is actually the one in trials that works the best. Then there is also another agent, which is tranexamic acid. Now, tranexamic acid is what we would call a blood clotter. So tranexamic acid is used to help reduce the actual blood flow into that's feeding the uterus, and it can also be used to actually help against strokes that are the bleeding strokes. So yeah, so Barnell has said, you need to tell employers if you are on warfarin. I worked with a lady who was on it and worked with a broken glass bin. So yes, so obviously there is an occupational hazard for people that are on blood thinners that they may need to make their employer aware of, especially if they've got a job where they're dealing with moving and handling. So when they're moving and handling, they're at higher risk of problems with catching themselves, causing either external or internal bleeding. And yeah, so it is something to be aware of telling employers. But I'm sure that when you get started on these sort of things, it's sort of thing when you've had an event, you'll be asking your healthcare provider, how long will you need to be off work? And then when you go back to work, is there any adaptations that are needed? Okay, so I've been on for an hour. So I've covered quite a lot. I'm getting quite warm. It is nice and warm here in the UK. It has clouded over a bit, so I'm not quite sure whether we've got a chance of seeing the aurora borealis tonight. I don't know whether anybody else has seen that. So as some of you may be aware, I am also a bit of a nerd when it comes to anything geoscience related, because I did do a geoscience degree just for fun. So anything when it comes to the Icelandic volcano, which is my special interest, it currently is the final cone that's been erupting has died. There's nothing in it. It went from a big cone to a small little cone inside it, and now there's finally nothing in it. But they are expecting that to erupt any day now. But currently, the solar storm is at one of the highest for the last 11 years. Solar cycles tend to be every 11 years, and probably wouldn't see it if you flew to Iceland at the moment, seeing as Iceland are pretty much getting on for sort of 20 hours of daylight a day. But here in the UK and some of the northern US have been seeing the aurora borealis the last couple of nights. I think I saw a whiff of it on, yeah, Friday night. I could see sort of the white wisp, but there wasn't actually any colour coming out of it. And unfortunately, my camera isn't any good at pulling colour out. Last night it was too cloudy, so I'm just hoping that I might be able to see it today. But I have already seen it twice in Iceland. So, but I don't know whether any of you else have seen it or are going to try and look for it. And then if I can ask that you like the stream, and once the screen once the stream has ended, if you could come back and write a comment, that's really good for the YouTube algorithm to push um, this live stream out to other people to watch. And as I said, my previous video this week was on PPIs. If you wanted to go back and watch that, I've got a whole section. I have got a standalone video on statins, which is a related subject to this, because quite often people that are high risk of strokes and heart attacks, they do the Q risk and see the cholesterol and start them on a statin. And then also let me have comments. So I will be putting on my community page sort of a poll for my next few videos, which you'd like me to do first. But give me comments on anything that you would like me to do, either in a live stream where you can ask questions or as a standalone video. Uh, okay, Mr. Angelab, it's been too cloudy. I know, that's the problem. The clouds get in the way. Laurie, I saw them often as a child in northern US. They are amazing when you actually do see them. I know when me and my mum first saw them the first time, we were looking, I'm like, is that it? Is it? Is it? Yeah. And we were stood in the middle of Reykjavik. And yeah, it was amazing. Um, Cal, sadly, no, not visible in Belgium. Uh, but the pictures by the Canadians and the Americans, oh, on the anti-MLM Discord, obviously, in the correct places, Cal. Yeah, the problem with the photos is they give you a false sense. So the new iPhones and the new, well, most cameras on phones now, you can put them for nighttime exposure and it really pulls the colours out. So the pictures that you are seeing being shared on social media are not what you see from the naked eye. They are so much more brighter because they're long exposure and are really pulling the colours out. They're not as bright as that to the naked eye. Um, right, so Mr. Angel Lad says you've seen them once in Iceland and once, I'm assuming you mean at home where you live. So, yeah, they are amazing if we get to see them. I have seen them before, but always a chance to go out and experience them again. So if I do get a whiff of them and can see them, I might go for a drive out. Anyway, lovely to see you all, have you all here in the comments again. Oh, yeah, you did say Eastern US. That's what you said. You were all wet and rubbish weather today. I'm not very good at remembering where everybody lives. I'm usually better at remembering what people's medication are rather than the location where they live. Although I do always keep everything confidential as a pharmacist. I try and sort of, yeah, decompartmentalize keeping confidentiality. But yeah, thank you all for joining me. And I don't know whether I'm going to try and move these to 2 weekly because these are the things that I have the best interactions with and get the most amount of watch time for. So although I'm now getting the subscriber numbers, I still really need to build up my watch hours if there's any chance of me ever getting monetized. But yeah, so yeah, bye Laurie, bye Cal, bye Mr. Rangelab. I'm assuming bye Mum and Dad. Ray, if you're still on. So great to have you all here. And I'll see you all again soon. Bye.